We are live now.
Good evening, participants and delegates. Thank you for joining Shield Connect. And today we are our famous series Icons with Dr. Ritu Santwani ma'am. And today our icon is ma'am herself, Dr. Ritu Santwani ma'am. And ma'am is going to take the topic role of folic acid in pregnancy. So let me introduce ma'am. Ma'am has done MBBS, MD, FICOG, FIOG, AMRCOG. Ma'am is obstetrician and gynecologist in IVF specialist, and ma'am is the founder and CEO of 360 Degrees Healthcare Studio. Ma'am is also consultant in Inamdar Multi-Speciality Hospital in Pune. Ma'am is infertility test tube baby specialist. Ma'am has also been part of NUHS Singapore, co-founder of MAAM and board member of SWWC. So I welcome Dr. Ritu ma'am on our platform, and she will speak on this topic. And I hand over the session to you, ma'am. Thank you, ma'am.
Yeah, thank you, Nishan. Thank you so much. And thank you, Shield Pharma. Thank you, Sahiti. So a very warm welcome to dear friends, those who all have joined. Yeah, thank you for joining. Some of my friends have joined from the Arab countries. A very, very warm welcome. Good to see you, Kanchanji here. So yeah, hi,
hello,
Dr.
Ritu.
Francis. Yeah,
hello.
hi. How are you, Kanchanji?
Fine, ekdam badhiya.
Chaliye, good.
You are also looking very beautiful.
Thank you, Kanchanji. Thank you so much. Good to see Dr. Francisco, Dr. Mona. Yeah, Dr. Deepika, Dr. Suman, Dr. Madhu. So friends, today in this series, today we are doing the last session of this year of 2022. Now we will meet in 23. Yes, on the 29th, I'm not going to take the session of this. So Nishan, please chill. 29th, we are not having a session.
Yes, ma'am. Yes, ma'am.
So sharing the screen. So friends, as we all know about the role of folic acid in the pregnancy. So when Shield, especially the Dr. Suman told me that, ma'am, are you going to take the talk on this topic? I was in the dilemma ki why to take this topic. So this topic is known by everyone, and who will come to attend this topic. But while going through the slides, while making the slides, some points come which we never emphasize, which we will never focus. So now, without wasting time, I'm starting the session that what's the role of the folic acid in pregnancy. So friends, today's my talk is focused on the role of folic acid. I'm not going through that whether to give folic acid or whether to give tetramethylfolate or what. So now what's the role of folic acid and how to give what the dosage we have to use. So as always, my presentations always start with the Mata Durga Rani Stuti. Now again, there is a fear of the fourth wave of the corona. So we will pray to Mata Durga. Ya Devi Sarva Bhuteshu Chikitsa Rupen Sansita Namastasyai 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 Namo Namah. We all know the folic acid is known as a pregnancy superhero. Most of the patients, those who are coming to consult us, and once they all are aware about the folic acid. Some tell ki, ma'am, we have started the folic acid 3 to 4 months prior, or once they are coming to us, if the pregnancy test is come positive, yes, madam, we are already on the folic acid. So now what's the role and how to proceed? So now these are the some questions, because I practice in Pune where the lot of the Google savvy patients are coming, and these are the some questions related to the folic acid. Friends, these I have what the questions you are able to see, these questions I have usually once my patients are asking me, I always have a habit to make that questions, write it down somewhere. And those who are attached with me on the LinkedIn, Facebook, or Instagram or YouTube, you can see I have posted lot of reels. I always make the reels on the whatever the common questions the patients ask. So these are the some questions. Does the folic acid make you sleepy? When should I take folic acid, morning or night? What is the difference between the folic and folic acid? What is the what happens if you take folic acid every day? Why my folic acid is low? What causes it low? What happens if I miss my one folic acid tablet? Is the B12 is as same as folic acid? Can I take B12 and folic acid together? What are the side effects of this folic acid? Can folic acid causes the weight gain? Other question, does the eggs have folic acid? What are the drinks which are having the high in the folic acid? These are the usual common queries which the patients ask in the OPD. So friends, as we all are aware, the understandings about the nutrition in pregnancy, fetal nutritional status is affected by the intrauterine and childhood nutritional experiences of the mother. Maternal nutritional status at the time of the conception is an important determinant of outcomes. Intrauterine nutritional environment affects the health and development of the fetus throughout life. Just a second, need water. We all are aware the top 3 best practices to improve the birth outcomes and reduction of the high-risk birth. To improve the access to medical care and healthcare services, encouragement of the good nutrition and healthy lifestyle is very important. Eating healthy foods, taking folic acid, either the folic acid or L-methylfolate, and the reduction of the harmful substances. So now coming that what is about the folic acid? Folic acid is a synthetic form of water-soluble B vitamin that is required for the DNA synthesis and cell division, and it plays a critical role in the fetal development. Make the normal shaped red cells. We know the megaloblastic anemia is maybe due to secondary folate deficiency, 8 times higher reported in the multiple pregnancies. We know the folic acid role in the prevention of anemia, helps in the prevention of birth defects. Studies have shown that the low folate status is in the preterm delivery, low birth weight, and the IUGR. Besides, there's the important role in the reduction of the blood homocysteine levels. So this is about the metabolism, how it acts. About the folate bioavailability. Not going on deep on this. So related to this, regarding with the role in the homocysteine metabolism, we all know the sulfur containing highly reactive amino acid that is synthesized during protein catabolism by the conversion of methionine to cysteine. Homocysteine is metabolized by transsulfuration depending on vitamin B6 and remethylation depending on folate and vitamin B12. Now the metabolism comes that what is the homocysteine risk? We all know deficiency of this folate, vitamin B6 and B12, raising of the total plasma homocysteine level, which in turn associated with endothelial dysfunction, alteration in hemostasis, oxidation of low density lipoprotein, activation inflammatory response, altered cholesterol and triglyceride metabolism in vascular cells, in turn responsible for the atherosclerosis, coronary artery disease, MI, stroke, thromboembolism, peripheral vascular disease. This hyperhomocysteinemia is a risk factor. The female who develop the severe preeclampsia have higher plasma homocysteine levels in early pregnancy than the women who remain normotensive throughout the pregnancy. The threefold risk has been reported. Hyperhomocysteinemia as a risk factor. The pregnant female with hyperhomocysteinemia have 7.7-fold risk for preeclampsia there are a lot of studies has been presented in the favor of this. This hyperhomocystinemia is associated with preeclampsia as well as eclampsia, but in eclampsia, the severity of homocysteine elevation is more compared to that in preeclampsia. So this hyperhomocystinemia acts as a risk factor for both maternal and umbilical cord plasma homocysteine concentrations were elevated in pregnancies, complicated by preeclampsia compared to the normotensive controls. So I think this I have already discussed. So now how does this hyperhomocystinemia leads to PIH? So this homocysteine is primarily responsible for endothelial cell damage, leading to proatherogenic effects, thromboembolic effects, and hypoperfusion of the placenta. It also has been implicated in the overproduction of the free radicals. So question comes that how does this hyperhomocystinemia leads to PIH? So friends is aware that the suboptimal methylation, increased levels of homocysteine, excessive generation of free radicals leading to oxidative damage, leads to DNA oxidation and endothelial dysfunction. So this suboptimal methylation could lead to a lot of pregnancy complications. This elevated homocysteine and reduced serum folate concentrations are the risk factors for recurrent spontaneous early pregnancy loss. Studies have shown that hyperhomocystinemia could affect the IVF outcome too. This maternal hyperhomocystinemia is associated with an increased risk of coronary artery disease. The occurrence of IUGR increased with low maternal and cord concentrations of folate and higher levels of this. So now coming to this is the mechanism that how in hyperhomocystinemia the folate is going to help. So we all are aware the foods which are rich in the higher good sources of the folic acid, the liver, nuts, peanut butter, dried peas or beans, juices like oranges, pineapple, tomato, fruits like oranges, avocado, cantaloupe is a good source of the folic acid. And of course, we all know the green leafy vegetables is the very good source for this. So a few lines about the difference between the main difference between the L-methylfolate and folic acid is that the L-methylfolate is primarily the biologically active form of the folate, whereas the folic acid or vitamin B9 is one of the several types of vitamins converted into the folate in the body. Among this folate and folic acid, the folate, the natural complex form, while the folic acid is a synthetic simple form. Foods such as dark green leafy vegetables, broccoli, asparagus, lentils, beans, peanuts, strawberries, kiwi, orange juice, and liver. And it can be lost through processing and cooking. The absorption rate is reported up to the 50%. While among this folic acid, it is the fully oxidized form. Terroyl monoglutamic acid have only one glutamate molecule attached, used in nutritional supplements and food fortification. Only form that can be transported across the membranes, and the absorption is very high, is reported up to 93%. So now what are the, there are reported some drug interactions with the folic acid. Among this, we can see, friends, the chloramphenicol, the methotrexate, phenobarbital, phenytoin means all the antiepileptic drugs. Among this, here we can see these drugs have the reduction in the folic acid levels. Among the drugs which has been used for this ulcerative colitis and Crohn's disease, sulfasalazine, and with this metformin also, the studies have shown the reduced effect of this, and along with it, the barbiturates and the trimethoprim also it has been reported. So now the question comes, who needs the folic acid? As we all are aware, all the women of the childbearing age group. Yes, but now these days we are seeing a lot of elderly primary also. That's why I mentioned that 14 to 40 who could become pregnant, and the pregnant females. Now, what the incidence and studies suggest? Studies suggest that 25% of pregnant women in India are the folate deficiency, congenital malformations, as we all know, neural tube defects, orofacial clefts, cardiac anomalies, anemia, spontaneous abortions, preeclamptic toxemia, IUGR, and abruptio placentae has been reported. So we all know that while giving this, the neural tube defects can be prevented. Neural tube defect cause of infant mortality. First is the congenital heart disease. Second is the neural tube defects. It folds on itself and forms a tube in the first month of the pregnancy. Yes, we all are aware about this, so I'm skipping these 2-3. So this slide demonstrates that if there is a failure of the anterior neural pole and the posterior neural pole, the failure of closure of the anterior neural pole results to anencephaly, while the posterior neural pole closure leads to spina bifida. So this is regarding the development of the fetus for the neural tube development. As we all are aware, this neural tube defects etiology can be multifactorial inheritance, single gene inheritance, and the Meckel-Gruber syndrome, aneuploidy, trisomy 16, 18, triploidy, teratogenic drugs, hyperglycemia, and sometimes the aberration of the folic acid intake and metabolism has been reported. Folic acid supplementation could modulate other adverse pregnancy outcomes. Seizures in women known with epilepsy or seizure disorders, preeclampsia, pregnancy-induced anemia, autism, fetal growth restriction, and the preterm delivery. We all know that folic acid supplementation is an important part of the prenatal care of the woman with epilepsy. Interference with the anti-epileptic drugs, we have just shown the chart, plays a role in the reduction in the incidence of the gestational hypertension and preeclampsia, and to correct the hyperhomocystinemia, optimizing the homocysteine pathway, reducing the risk of the autism is under study. And of course, in the anemia and pregnancy, we are giving this. So these 2 points are very important because the studies, a lot of studies, once you go through the net, lot of studies in the Medscape are also available that how it helps in the reduction in the incidence of gestational hypertension and preeclampsia. I usually tell the patients, because the patients were coming, this Google Savvy and all that, ma'am, we are having a lot of green leafy vegetables. What's the need of taking of then again separately the folic acid tablet? So usually I am having these studies handy on my mobile, and once the patient says like that, I usually forward them on this on their WhatsApp, that what's the importance and why it is needed. So as now coming to the now what's the dose of the folic acid? So the low risk group, as we all are aware, 0.4 mg per day, beginning 3 months before the conception, continuing throughout the pregnancy, and for 4 to 6 weeks postpartum, or as long as the breastfeeding continues. While in the moderate risk group, it has been reported 1 mg per day, beginning at least 3 months before conception and continuing until 12 weeks. Then 0.4 to 1 mg per day from 12 weeks continuing, and 4 to 6 weeks postpartum, or as long as the breastfeeding. And in the high risk group, the 4 mg per day, beginning at least 3 months before the conception, continuing till 12 weeks. So similar rate has been reported. So friends, as we all know, the folic acid dosing with the above recommended supplementation amount has not been shown to have any added fetal or maternal health or developmental benefits, although the recent epigenetic and methylation studies in animals and humans have indicated that some caution and research is required. The folic acid doses of 5 mg have not been reported to the maternal or fetal risk, but long-term high-dose 5 mg folic acid use has not been well studied in prenatal population. Recent summary conclusions from the colorectal cancer reviews on the topic is still cautionary. There are only some studies which are showing that in the fair, not supporting for in the use in the patients of the colorectal cancer. And besides that, the 2 studies have come which have shown no association of the folic acid with the colorectal adenoma or recurrence. So now how it affects and the timing in the pregnancy, as we all knows, in the neural tube defect, yes, the preconceptionally and in the first trimester, the significant benefit by giving the folic acid, while in second and third trimester, no additional benefit has been reported. While in the patients of the preeclamptic toxemia, yes, in the preconception period and in the first trimester, it is beneficial. Yes, but in the second trimester, it is significantly benefit, and third trimester, again, it is reported as beneficial. This is all, as I've shown in the earlier slides, is due to endothelial dysfunction in the patients of the PET. In the second trimester, the lot of good results has been reported. Yes, in the patients of anemia, of course, it is beneficial. In the patients of IUGR, yes, in the preconception and first trimester, significant benefit, while in the second trimester, beneficial. While in the patients where the in the preconception and first trimester is beneficial, while in second and third trimester, no additional benefit has been reported by the studies. Anyhow, once we give the folic acid, yes, if the patient is willing to take, we can continue throughout the pregnancy and lactation. Yes, but later on, after the first trimester, as we start the iron, most of the iron preparations are having along with them the folic acid is also. So studies have shown that women are advised to maintain a healthy folate-rich diet. However, this folic acid supplementation needed to achieve the red blood cells folate levels associated with maximum protection against the neural tube defects. Again, these studies have shown that women in the reproductive age group, 12 to 45 years of age group, advised about the benefits of a folic acid in a multivitamin supplementation during the medical wellness visits, the birth control renewal, pap testing, or the yearly gynecological examination, whether or not the pregnancy is contemplated, because so many times the pregnancies are unplanned, and this applies to all the women who may become pregnant. So this is also very important. Then third, the category comes, the folic acid supplementation is unlikely to mask the vitamin B12 deficiency, pernicious anemia. Investigations are not required prior to initiating the folic acid supplementation for women with a risk for primary or recurrent neural tube or other folic acid sensitive congenital anomalies who are considering a pregnancy. Then it is recommended that folic acid be taken in a multivitamin including 2.6 microgram per day or vitamin B12 to mitigate even the theoretical concerns. So there are different studies has been reported. Similarly, a study has been reported, the MRC study in the UK, the International Multicentral Double-Blind Randomized Controlled Trial. They have recruited around 817 women who had a previous affected pregnancy. Among this, they have divided into the 4 groups in the A, in which the folic acid 4 mg per day, In the group B, the folic acid and multivitamins. C is neither is given. In the D, the multivitamins has been given. Then they have done the evaluation of the effects of folic acid or other vitamins in the comparison of the groups A plus B and C and D, or the group B and D and A and C. This study has been reported long back in the Lancet. So the studies have shown that folic acid has a significant protective effect. Around 71% cases have shown the protection, while other vitamins haven't shown the other such significant effect. So studies have shown that, yes, that it reduces the risk of the neural tube defects. So 4 mg folic acid per day before pregnancy and throughout the first trimester has shown around 71% of the protective effects by this study. Other benefits of this is the additional birth defects. What it covers: the orofacial cleft, congenital heart disease, urinary tract anomaly, limb defect, and it may prevent the cardiovascular disease, cancer, the colorectal cancer, the colorectal adenoma, Alzheimer's disease. Like this, so many studies has been presented. So the challenge is the neural tube defects happens in the first month of the pregnancy, before the most of the women know that they are pregnant. So half of the pregnancies are not planned. So our main motto that it should be prepared. So we have to educate our women properly for this folic acid intake. This is by the CDC recommendation that around 400 microgram per day. All of the women of the childbearing age group in the low risk women. Then 4 mg per day in here we can see, friends, in the low risk the 400 microgram, while the female with the history of neural tube defect, it is around 4 mg per day and 1 month prior to the conception and during the first trimester. So it's better 1 to 3 months prior to the conception, and only the dose in which the history of the neural tube defect is 4 mg per day. This study has been, today when I'm making the presentation, so this study is very recent, presented in August 12, 2022 only by Stephanie Watson. He has presented the criteria that how much folic acid is recommended each day in the terms of the pregnancy. When you are trying to conceive, 400 microgram. From first 3 months of the pregnancy, 400 microgram. For months 4 to 9 months of pregnancy, it has been recommended 600 microgram, and while breastfeeding is 500 microgram. Though in our India, of course, we are not getting such different preparations like 400, 600, and 500. Only the 400 microgram preparation we are getting. Yes, now some companies have come with the other preparations too. The studies have shown for this folic acid recommendation for the recurrence prevention, the patients who are having a history of the recurrent babies of the neural tube defects, the current recommendations that these women would consume the 4,000 microgram of folic acid each day, beginning 1 month before becoming pregnant and throughout the first 3 months of the pregnancy. Women who had neural tube affected pregnancy should consume, see friends, this is very important, 400 microgram of folic acid each day, even when not planning to become pregnant. So this slide is very important. Means these are some few slides. Once we make the presentation, we came to know the some points which are very important. Like this, the female who had earlier a neural tube defect affected pregnancy should consume 400 microgram folic acid every day, irrespective whether she is planning or not planning for the pregnancy. As I've shown in the earlier slide, sometimes these pregnancies are unplanned. And plus the patients who are already having a history of this neural tube defect that would consume 4,000 microgram of folic acid each day, beginning 1 month before becoming the pregnant and first 3 months continuing the pregnancy. So means all the time they have to take 400 microgram, and when they are planning to have a baby, at least 1 month prior, they have to start the 4,000 microgram, and that has to be continued for the first 3 months. So as we all aware now, the folic acid is added in some grains. We all know it has been in the green leafy vegetables, broccoli, peanuts, citrus fruits. These are the different sources that how much of the folic acid in this. So in the peanuts, in the beef liver, in garbanzo beans, pinto beans, lentils like split peas, black beans, kidney beans, black eyed peas, and cooked spinach, we all know is a good source of the folic acid. In the corn and the asparagus too. So the take home message is the folic acid is the one of the important nutrient in the pregnancy, and it has to be taken at least 1 month before and during the first trimester of the pregnancy can help to prevent the neural tube defects. Females of childbearing age with no history of neural tube defects should take 400 microgram of folic acid daily, while with the childbearing age group with the personal or family history of neural tube defect will take 4000 microgram of the folic acid. So this is, we have just discussed that why it is important. Then we have to encourage the women to take folic acid supplements and to eat the foods rich in the folic acid, like fortified breakfast cereals and yeast extract, and consume the foods and drinks rich in the folate. So thank you friends for your patience and time. I know the topic is very well averse to with all of us, but these are the some points which I want to focus. That what about the dosage in the patients of the having a history of the recurrent neural tube defects. So that's why I thought, yeah, I must take this topic. Yeah, good to see Dr. Susan. How are you? Dr. Chinmay, yeah. So many
I'm
friends
good.
have
I'm
joined.
good. I was able to join towards the fag end of the session. I'm really sorry. I wish I joined. I hope to watch the live recording.
You can see on my YouTube that the session is gone live on my YouTube channel.
Okay, I'll go ahead and watch that. I just stepped in.
Acha, okay. No issues. Hi, Shivani. Good to see you, Dr. Shivani. Yeah. Hi, Renu ma'am.
Yeah, hi Ritu. Very nice presentation. बीच में call आ गया था, so I had just gone. But yeah, I was there. It was really nice.
Thank you, dear. Thank you,
वो
dear.
slide
Hi,
थी
Dr.
ना,
Asha.
folic acid benefit first trimester and benefit preeclampsia benefit. That is very nice slide.
Thank you, dear. Thank you. Good evening, Geeta madam. Good evening, ma'am. Ma'am, you're muted. Geeta madam, you're muted.
I will just see that. Okay, it's okay?
Yes,
Now it's
ma'am.
okay.
Yes,
Yeah. You spoke so nicely in a very common but a very interesting way. That's nice. I heard it.
Thank you, madam. Thank you, ma'am. Thank you so much. Yeah. Hi, Dr. Asha. Good to see you.
मैम आई वांट टू आस्क वन थिंग मैम आपने बताया कि
Yes.
जहाँ पर फैमिली हिस्ट्री है न्यूरल ट्यूब डिफेक्ट की वहां पर हम डोज जो है वो 4000 माइक्रोग्राम दे रहे हैं
जी
मैम जो अवेलेबल है दैट इज इन द डोज ऑफ 400 माइक्रोग्राम देन मैम हाउ वी गिव दिस
कुछ प्रिपरेशंस है ना, आप देखो ना, कुछ प्रिपरेशंस है ना जिनमें 1 mg तक है. Some I can't take the brand names here. कुछ प्रिपरेशंस है ना आपके पास जिसमें 1 mg तक है.
ओके ओके ठीक है मैम
We can discuss in that group the brand names if you want. In the south kind of group we can discuss there.
जी मैम
Yeah.
थैंक यू मैम.
Yeah, thank you, Dr. Vijay, for joining. Renu madam, good to see you. Dr. Chinmay. Yes, Renu madam, saying something. Yeah. Good evening, madam.
I'm sorry I am late. I was just busy.
No problem, ma'am. No problem.
It is
Good to
always
see you,
nice
ma'am. Good to see you.
and
Yeah.
to listen you. Your orations are very good. I really love it.
Thank you. Thank you, ma'am. Thank you so much.
Everything is
Thank you so much. Thank you, ma'am.
It is good
How
to
are
see
you, Dr. Chinmay?
also.
Dr. Chinmay is joined from the Nigeria. Yeah, how are you, Dr. Chinmay? I think is. Yeah, thank you, Dr. Vijay. Dr. Vijay Chan, great friend. Thank you. Thank you, Dr. Madhu. Thank you so much for joining. And thank you for your comments. Thank you. So this is the last presentation of this year of the 2020-22. Everywhere the Christmas vibes are there. I think you are able to listen some noise also, because my home is near of this lot of happening places near my home. So everywhere the Christmas celebrations are started. So to all of you. Yeah.
Yeah, even your
So-
backdrop is red. It is very, very Christmassy.
Thank you,
Looking
Shivi.
also very nice, very festive you're looking.
Me? I am coming directly from the OPD. Anyhow, thank you. Thank you so much, dear. Thank you. Waiting to welcome you in Pune on 14th and 15th. Dr. Shivani, warm welcome. So,
Yes, thank you. I'm
yes.
also looking forward to coming.
Yes, darling. Yeah. Renu, madam, are you coming to Kolkata? So we will meet there.
Made a program. Because I am going to Bangalore in the end of this. Yeah. So.
Okay. So friends, with this, we will wind off for the today's session. Happy holidays to all of you. Yes,
Same
Merry
to you.
Christmas and happy holidays to all of you. And in advance, the Happy New Year. I think we will start our next session on the second week of the January, because in the first week of January, most of us in the Kolkata. So probably the next session will become on the second week of the January.
Okay, bye-bye.
Okay, great.
Good night,
Yeah.
Dr. Ritu. Good
Yeah,
night,
good night,
everyone.
good night, good night,
Looking
good night.
forward.